I want to thank you for coming tonight. My name is Joyce Riggs. I'm the Director of Community Development and Planning for University of Maryland, Charles Regional Medical Center, formerly Civista Health. And so I want to thank you for coming here this evening for our annual didactic presentation on prostate cancer. And we have a terrific panel for you tonight. That I'll introduce, and the way tonight will work is I'll introduce them, each of them will speak briefly about their topic, and then we'll open it up to question and answers afterwards. Sound good? Okay. First, I'd like to introduce, this is Dr. Boris Naydich. He is a board-certified radiation oncologist with Chesapeake, Potomac Regional Cancer Center that's located in Charlotte Hall and Waldorf. Did I miss a location?
No.
Okay.
That's right.
And last but not least, is Dr. K, or Dr. Kakitelashvili, and yes, I practiced that many times before I say it. He is board certified in urology, and his practice is located on Centennial Street in Plata, Maryland. So without further ado, we'll start with Dr. Naydich.
So I'm a radiation oncologist. Radiation oncologist is a doctor who is treating cancer with radiation, with use of radiation. So we have multiple modalities of radiation therapy available for patients with different cancers. Over the last 10 years, 15 years, we witnessed tremendous evolution of technology that would allow to deliver radiation very accurately, with high precision, very safely, and with high efficacy. So now we see significant improvement of outcomes in patients with prostate cancer, breast cancer, rectal cancer, and multiple other malignancies. So radiation therapy is a highly technologically advanced area of medicine. So we treat patients on linear accelerators. The treatment plan is developed on very advanced computer system that process thousands of images and select an appropriate area of interest what the tumor is. So such treatment is killing cancer cells, destroying tumor, and preserving normal tissues. Modalities of radiation therapy not limited to external beam radiation. We have so-called brachytherapy. This is a modality of radiation which is delivering radiation from inside. One example is a placement of radioactive seeds for prostate cancer patients. And we have a long-standing program in a hospital where we treat such patients. Dr. Kakitelashvili is a urologist who is participating in this program. We have several other urologists working with us, and collectively, radiation oncologists and urologists treating these patients, putting radioactive sources inside of the prostate gland with excellent outcomes. Of course, any treatment may produce side effects, but with contemporary technology, we minimize risk of such complications, and the results of the treatment are constantly improving. But also with a brachytherapy, when we put radioactive source inside of the cavity, surgical cavity, and the results are also very good and very promising. We treat gynecological malignancies, and very soon, here in Southern Maryland, we have a stereotactic radiosurgery, the technology that would allow to treat brain tumors with margins of several millimeters, very accurately, very precisely. And the local citizen will not need to go to Washington, D.C. and Baltimore to receive such treatment. And the technology continues to progress. Maybe in 5 years we'll sit here and talk about new modalities of the treatment.
I'm the one who is selecting, who's basically diagnosing prostate cancer, selecting proper people for prostate biopsies, and then offering them all ranges of treatment that were mentioned above. I'm the one who performing surgical treatment. Currently, we are performing robotically assisted radical prostatectomies. Unfortunately, there are no robots in Charles County, but I'm taking patients to Montgomery County and performed several dozens of procedures in suburban hospital. It's one of treatment modalities of localized prostate cancer is robotically assisted laparoscopic prostatectomy. And offering people different other modalities, including radiation, sending it to Dr. Naydich, cryotherapy, and other modalities. And actually, I'm the one who is diagnosing, who is counseling people whether they need to be diagnosed with prostate cancer, whether it's wise for them to get biopsy, and so forth. So probably I can start a little bit by explaining why we're not doing this year that community-based screening that we used to do every September in for many years. The reason for that is that there was a series of newly developed guidelines about screening for prostate cancer. And there's, I don't know whether you have this handouts, there are two sets of new guidelines. Presidential panel from 2012 and American Urological Association guidelines from April of this year. They're different, but both of them are inclined for less aggressive screening. There are some differences between them, but that's probably the reason we're not going to be doing community-based screening anymore. One thing I want to emphasize here, although these two guidelines are there and they're based on very reasonable studies, most of urologists feel themselves under no obligation to strictly follow them and use their many years, who has 10 years, 20, 30 years of experience in making decisions between the patient and the doctor who needs to be screened, who needs to be biopsied, because one caution, that guidelines are based on very big population studies where dozens of thousands of people involved, and statistical difference may be very negligible between screened and unscreened population. But if it comes to individual patients, individual saved life, and people who are, between the ages of 45 and 55 when routine screening is not recommended anymore, then, your opinion changes because you see these real people. You don't work just with numbers, you see the people. And basically every 2 weeks I diagnose somebody in the age between 50 and 60 with prostate cancer. So reading these guidelines is good, but it's not the fact that we will going to follow them very strictly. That's what my kind of short comment here. Undisputable fact that in the last 10 years population was overscreened. People had done PSA when they should not be done. People in the 80s, or routinely people did every visit. Primary care physician did it every 3 months when it needs to be done only 1 year or once in 2 years. So really system was overcharged with money. And a lot of primary care physicians, I don't want to tell anything bad, but they don't exactly know how to use PSA in the overscreened population. And that's why there was movement to create these guidelines and to see. And really, if you see big statistics, when you see thousands of people, yes, the benefits of screening, if you compare, actually you need to treat 48 people for prostate cancer to save 1 life. And you need to screen thousands of populations. If you compare a screened and unscreened population, you save less than 1 life in unscreened population and more than 1 life in screened population. So difference, if you're looking at big numbers, is really not very big. But at the same time, this panel, American Urological Association panel, emphasized that on screened population, the mortality rate significantly went down. This is undisputable fact. So the facts are not necessarily, they sometimes contradict each other. So, but it's an undisputable fact that mortality rate in the United States from prostate cancer decreased significantly. And in 1980s, 2/3 of presentations of prostate cancer was locally advanced or metastatic prostate cancer. Now I think it's less than 10% presentation of prostate cancer as such, and that's unscreened people, obviously, because they were never screened. So, yes, screening should be much less aggressive than we had. Yes, and there is an alternative kind of guidelines that Sloan Kettering offers. to do not aggressive screening, but to do certain points, you know, to do a baseline screening in mid-40s. And depends what PSA is. If PSA less than 1, next PSA point probably should be sometime between age of 51 and 55, not every year. I agree with that. And if PSA is 3, then discuss biopsy. And between 1 and 3, then, you know, do PSA every 2 years. And, you know, certain age marks here are different for, you know, different ages, between 50 and 70. Depends on PSA. The next PSA, the timing on next PSA should depend on the value of prior PSA. So really, in certain people, PSA should be probably measured maybe 3 or 4 times in the lifetime. And last PSA should be measured around the age of 70, 75, and never measured again. Not every year, not 20 times, you know, but we're still not there at the end point where we totally understand the right rate of measurement of PSA. And again, you know, there's always a risk of missing somebody with prostate cancer. And really, prostate cancer becomes younger and younger. And sometimes aggressive prostate cancer is between age of 45 and 55. And so if you strictly follow this presidential panel guideline, these people will be dead. And actually price will be, what this presidential panel can get away with that recommendation easily, because these people will die not now, not 5 years from now. They will die 10 to 15 years from now, but everybody will forget about these people sitting on this presidential panel, because the lead time for death of prostate cancer between 10 and 15 years. So unscreened population will be dying 15 years from now. And who knows where we're going to be in our healthcare environment 15 years from now. So it's very, very easy to get away from that, you know, recommendation. I don't know, maybe some of my colleagues disagree with me.
It takes about 20 to 25 years to see the whole consequence of this event. Now, some mathematical models predict that if we stop screening in people that belong to a high-risk group, you know, young people from African-American segment of population, people who had a history of prostate cancer, then what may happen in 25 years, we may lose human life. As a matter of fact, in 25 years, if we continue to follow outcomes of the screening for 25 years, then we will see that it would be enough to diagnose 2 cases instead of 48 to save 1 human life. Now, let's do some mathematics. We know that out of 1,000 citizens, 5 will die from prostate cancer. The presidential panel actually noted that, you know, screening of 1,000 people would save 1 human life. Right? So let's do some mathematics. Instead of 5 people, 4 people will die. It would mean that reduction of the mortality is 20%. Now, if you can imagine that 1 million people will have that screening, then we'll save 1,000 human lives. 10 million, 10,000, and so on. So the screening is very expensive. That's one of the concerns of the panel, that we spent $3 billion in the United States for the screening. And now the question is, does it worth to spend $3 billion to save 10,000 lives of Americans? That's a very important philosophical issue. Now, there are multiple ways to reduce the cost of such screening. If the screening is not done every year, or done every 2 to 3 years, that would instantly reduce the cost by factor 3 or 4. And there are multiple other ways. For instance, careful selection of the risk groups would allow us to screen less people with more effectiveness. That's a somewhat controversial issue, but what is not controversial, that screening in the United States saved thousands and thousands of lives. In 1975, the mortality was, from prostate cancer, was 40% higher. And we diagnosed advanced stages only because there was no screening, actually, and the people would come only when the cancer would reach stage 3 and 4. And the outcome of that treatment for stage 3 and 4 is not as good as in the early stage. So whatever debate is, we are talking about overall outcome in terms of the human cost. Of course, screening may produce some potential negative consequences, and the panel is actually talking about that. But the big picture is not as simple as it was depicted by the panel. By the way, it's not only my strong feeling that cancellation of the screening in the United States will have a huge cost in terms of the health in population of our country. It's a sort of collective uneasiness. And a very interesting report came from the state of New Jersey. New Jersey decided to continue on with the screening, and that decision was made by unanimous vote by Democrats and Republicans in both houses of New Jersey. So it's a kind of collective decision, and the state of New Jersey will continue to do screening, obviously with some modification or some improvement of it.
Probably we did something right in the last 10 years that mortality rate went down. You know, again, we overscreened, and that needs to be pulled back, obviously. But we need to come to some kind of reasonable middle here. Not to overscreen, but again, life was saved because of early diagnosis, and early diagnosis was done because of PSA screening. That remains, it's a treatable cancer. Advanced cancer is very difficult to treat or cure. The high-risk cancer, sometimes it's just 20% cure rate, even with new advanced techniques. So that's something to remember. The answer is these two modalities complement each other. One of them is not enough. You need both. I recently diagnosed a very high-risk prostate cancer on a young 53-year-old man with totally normal PSA, 1.7, and I did biopsy only because I was not happy with digital rectal exam. Why digital? Because digit is another name for finger. So it's not digital, computer digital, it's a
digit.
Digit is a finger, right. And on the other hand, some people have what we call T1C disease. So the digital rectal examination is totally normal, but they can have very high PSA. I diagnosed recently a man with normal digital rectal exam. He came to me, he had PSA done somewhere else, and it was 40. You saw that patient too. So one is not enough. It's both should be normal, then you're okay to go for another 2, 3, maybe 5 years. So if each one of them is not enough.
PSA, it's a prostatic specific antigen. This is a protein. It's a blood test for that protein produced by prostate gland. And the level of that protein is going up when people have a number of benign conditions, and particularly when the people have prostate cancer. Digital rectal examination, as Dr. K explained, this is a physical examination. So it's done by human finger, digit, is a translation from, I believe, Greek, if I'm not mistaken. So they're indeed complementary, and Dr. K gave excellent examples when one test may be normal and another one is abnormal. What is interesting in our practice, we see that PSA has a dominant role in the screening, because most of the patients we see now are patients with a cancer which is not detectable with a digital or finger examination. That's why the screening with PSA is important. I want to add something. You see that task force presented screening as a potentially harmful and potentially very bad thing that may harm patients. But we have to remember that PSA test, it's a blood test. It's just test. It cannot cause possibly significant harm. It's what we're talking about, cost of this test. I cannot tell you exactly how much it costs, but you know, that's in essence, I think, of the thrust of the statement that made by the panel.
Normal PSA values are age dependent. For people less than 55 years old, normal should be less than 2.5. Between 55 and 60, they should be around 3. And then more than that, it's all arguable, between 3.5 and 4. And then another aspect that you rightly mentioned is such thing as PSA velocity. If it's increased more than 0.75 in 1 year, then even if it's normal values, it's also worrisome. If it went from 1 to 2 in 1 year, it's something to be concerned about. On the other hand, and that becomes already something that not every primary care physician knows, you need to look at the whole picture, because really, big increase from 1 to 6 in 1 year, it's probably nothing. It's just little prostatitis, So just small increment increase, that's suggestive of prostate cancer, but it's already specialty. So, that actually comes back to overscreening. A lot of times PSA was checked, and I still see it now. PSA is checked when it never should be checked. When somebody has urinary tract infection and concerned patient comes to me with PSA of 30, and after 4 weeks of Cipro, it's back to 1.5. So that's where the PSA was wrong, misused, and that's where these guidelines came to us, because everybody used PSA is it's like a invention of penicillin, which penicillin was used for every flu like 50 years ago, right? And now we have resistant strains. So same thing.
Well, when we talk about this presidential panel or task force, we call it, we're asking question, okay, how this panel made such a decision? Why? Based on what information? And one of the points for criticism was that it was not well-defined a cut point when people had the biopsy. It was not flexible. For instance, an American preventive trial, which was one of 2 studies, which was put on the basis of the recommendations, the cut point was 4, no matter what. While Dr. K mentioned for different ages, it's different. And velocity was not used for the selection of the patients for the screening. And multiple other available tools were not utilized. In the European trial, the cut point was 3. Why 3? Why 3 selected for all ages? Very difficult to say. So if we would have designed a trial which would use a flexible and very scientifically determined and proven criteria for the cut point when we have to do biopsy, then I think the outcome of this trial, both trials, might be different. By the way, European trial did show some benefits of the screening, actually quite substantial benefits. It was a 29% reduction of the prostate cancer-related death in patients who had a screening.
PSA, although it's a not specific test, again, it can be elevated with benign enlargement of prostate, with inflammation and other things. It's still the best one we have. There are other tests. I probably will. There is PSA test, which is it's a urine-based test, which is probably close to what you're mentioning. Again, still not as good track record as PSA. Although again, PSA is not specific test. Yeah, I'm not familiar with that specifically, but I think it's same as PCA3 test, which is a urine test for prostate cancer. Some urologists use it, some don't. It's antioxidant, and common sense tells you that antioxidants reduce the rate of mutations, and they should reduce chances of cancer. But there are no strong level A, B, or even C evidence that that's the case.
It's a very interesting question, because what's happened, most of the people, all of us actually, trying to find something that may help us to decrease risk of the cancer. What we know at this point, if we take a big look at the big picture, available trials, meta-analysis, review of experts on certain products and certain things. So what we know that there are several things that are associated with increased risk of cancer, and one is a natural risk, it's age. So the older we are, the higher risk of prostate cancer is. Second one is a racial, ethnic kind of things. We know that African Americans have a higher risk to develop cancer, and actually it's a more aggressive cancer than in Caucasian population. And all other things, unfortunately, were not proven effectively and scientifically as a way to affect, risk, either in positive way or negative way. So all these products, when you analyze those reports, you'll see positive studies, negative studies, no conclusive data that would show that any other factors, anything else, would affect risk to get cancer.
My recommendation, first time at the age of 40, and if everything okay, if PSA is less than 1, don't do anything for 5 years. I think that makes sense. Now, if PSA is more than 1, between 1 and 3, I agree with Sloan Kettering. Maybe you need to be rechecked every 2 years. If PSA more than 3, then it's a different story. Maybe you need to think about biopsy.
This is a point that was made by a panel of experts at National Cancer Centers Network. So what they did, they analyzed what would be the model that would help us to effectively use those tests. And again, we have to take a very careful look who is going to have a test. For instance, for you, we know that an African American segment of population, the cancer is more frequent, more aggressive, and therefore the screening should be started early. And baseline test, as Dr. K said, is very important. If your test is negative, then next one might be done in 3, 4, 5 years. Depends on other risk factors that you have. Say, if in your family somebody had the cancer, that you have to do it more frequently. If not, that maybe you have a baseline test and next one will be done in 4 years. For people who have a low-risk cancer because of their ethnicity, for instance, Asian people have a very low risk of prostate cancer. They have a baseline maybe done at age 50, and then next one 5 years later. So what I'm trying to say, it's got to be very carefully tailored. And at present time, we don't have any national guidelines that would summarize all these, details. And when you take a look on the guidelines developed by National Cancer Center Network, by American Cancer Society, by American Urology Association, and by other experts, you will see significant differences in the interpretations and recommendations. So I think what it would be helpful now is to talk to the doctor, Dr. K, urologist, who is doing the screen, who is familiar with literature, with any doctor who is actually professionally involved with the treatment and screening of prostate cancer. Talk to the doctor to find out what your individual circumstance might be. And then, based on that information, you proceed with certain individually tailored screening program.
Usual answer is no, but except a couple of medications for benign enlargement of prostate, which are finasteride and Avadart. They artificially decrease your PSA. So if you take either of this medication for more than 6 months, your real PSA is twice as the measured PSA. So if your PSA is 1, your real one is 2. If you on either of these 2 medications. Other medications not definitely proven to change anything. If you have symptoms of prostate cancer, it means that prostate cancer is really very locally advanced or metastatic. That's the whole point of screening, to diagnose it before you have any symptoms. The right answer to your question is no, because the symptoms related to prostate, it's probably symptoms of infection, benign enlargement. If symptoms are related to prostate cancer, it's probably unscreened population. You probably will never screen, and if the symptoms are really related to cancer, probably very locally advanced or metastatic cancer. Now basically, but symptoms are the same, related to urinary, difficulty urination, but some people in unscreened population develop systemic symptoms even before they develop local symptoms. It could be bone pain because of metastasis somewhere. By age, without any symptoms, just by age, because you're just person who reached certain age, and maybe some other factors. On the father's side, somebody had prostate cancer, certain ethnicity, but the whole, no symptoms. Just you reach certain age, like women at certain age want to have her first mammogram, without any particular reason, because she's a woman. That's all.
When the PSA test was not available, people would go to physician with urinary symptoms. And what would happen? Most of them would have benign condition, benign prostatic hypertrophy. But in some of these patients, when the surgeons, like Dr. K, did a small operation called transurinary resection to improve urinary flow, they incidentally found cancer. So it was one of those situations when you have a urinary symptoms and go to the physician for different reason, and the physician would find a prostate cancer. But thanks God, those times are over. And now what's happened, we see most of the cancers without any symptoms. And when they come into us, we do rectal examination, I would say digital rectal examination, and we don't feel anything. So it's basically normal physical examination and the patient has a cancer. And this is way to go. When you diagnose cancer, when it is not detectable at physical examination, when PSA is still low and the grade of the cancer is low, that cancer may be not treated. And it's a good idea just to observe it. But we have to continue observation on a regular basis. And this is a reason why we recommend active surveillance, because some cancers, actually very many cancers, would not need to be treated at all. So when you have that patient who does not have any symptoms, when the tumor is not palpable, PSA is low, and the grade of the tumor is low, this person may be very safely observed. Well, you can imagine if we don't have any screening, we'll have only people with advanced disease. Well, it's a great question. What can be done? What can be done? And that's a question we're all asking. What might be done to mitigate this risk? Unfortunately, what's happened, we cannot mitigate the risk, but what we can do, if we have a healthy lifestyle, if we avoid risk factors like smoking, while it's not directly related to prostate cancer, we improve the quality of our life. We increase potential of our immune system. So our body may resist infections, may resist other disease, and maybe it would cause also prevention of certain cancers. So the healthy lifestyle, it's number one. Number two is a reading of literature and understanding of how things work and what might be done to improve your overall health. Those things might be very productive. But beyond that, I don't see what we can do otherwise. So it's education, self-education, and a healthy lifestyle.
Well, all panels recommend stop screening PSA more than age of 76. Again, I'm not totally with it. Some people are healthier than others, more life expectancy. My recommendation is if your PSA is less than 4, don't do any more PSAs. That's the only thing, because your risk of dying from prostate cancer is 0. So don't waste time of doing PSA testing, all right?
The most of the panels of experts in the United States agree that indeed screening at age group of 75 plus would not affect length of life, or life expectancy they call it. But all of them also agree with very important observation that people at age 75 may have a life expectancy of 20 years and maybe as robust as some 65-year-old people. So the age itself is, while being important, it's not decisive element in selection of your individual health program. And I think society is making, in general, at large, would make mistake if we put age as absolute and the only criterion, only factor to determine, if that person would benefit from screening or not, no matter what studies we have. I think that life expectancy is extremely important. Your physical condition is very important. So if you are maintaining a healthy lifestyle, and if you don't have major medical conditions, and if your life expectancy is more than 10 years, you are absolutely eligible to continue screening because you may benefit from it. Because if the screening will determine that you have a high-risk prostate cancer, the treatment may save your life.
Some biopsies are positive, some negative. And the question is, if you have a negative biopsy, does it mean that you don't have prostate cancer? And the answer is no. The chance of detecting prostate cancer on the first biopsy is 70%. So if you have prostate cancer, there's a 60 to 70% chance it will be detected on first biopsy. And the answer is continue monitor PSA once a year, once in 2 years. But here there is a new development in the last 2-3 years. in my office, all negative biopsies go to the secondary lab for special DNA methylation test, because it was found that prostate cancer, and prostate cancer is a field disease. In average prostate with a cancer, there are in average 7 independent foci of prostate cancer. But it was found that each of these foci has a certain halo of the normal tissue, which is not cancerous tissue, but it looks different. So the secondary lab, and it takes about 2-3 weeks, sends me a different report where to look and which part of prostate look more particular if you do second biopsy. And some of my colleagues in other areas of Maryland that do it for years, they did a specific targeted second biopsy and found prostate cancer where this test told them to look more aggressively. So that's the answer. I had people whom I biopsied second, third, sometimes I found cancer on the 4th attempt, but each biopsy has a certain reason to be done, certain discussion, and it could be years between biopsies. Sometimes it's months between biopsies, because there are certain precancerous conditions, not cancers, but certain atypical cells that very suspicious but not diagnostic for prostate cancer. So pathologists no answer to these questions. And there's discretion to each patient whom to offer biopsy in 3 months. If some young person who had no cancer but in like 5 course had atypical cells, of course he needs to be biopsied in the next 2-3 months. Now, if cancer is detected, this is a whole other area, what to do. Which cancers, there are more and more cancers that could be followed, so-called very low-risk cancers. Not simply low, but very low-risk cancers. It means that they need to answer certain criteria that it's safe to follow them. And follow-up means active surveillance. It's not only PSAs in that situation every 4 months, and the digital rectal exam every 4 months, but rebiopsy every 1.5 years. I have couple dozens, maybe 3 dozen of patients who just strictly following with me. So we do nothing. They win in terms of quality of life because they don't undergo treatment. But they come every 3-4 months. You will keep a pulse on the cancer, making sure that it's not getting worse. And I'll be honest with you, I have several people who are doing it for almost 8 or 9 years since I'm here. I had one person was diagnosed in 2005, and we still follow him, didn't do anything. He had 3 or 4 biopsies to make sure that his cancer is where it was in the beginning, and he didn't undergo any treatment. Some cancers don't behave aggressively, and it's okay to do like that. Some cancers need to be treated. There are so-called Hopkins criteria, and cancer is only in 2 cores, and each core has less than 50%, then it can be followed. So, and they enjoy quality of life without being, treated with surgery or radiation and doing fine, So that's one option. And more people are going through that. And what is interesting, in guidelines, there are no age limit to that. I mean, I'm not encouraging 50-year-old person with a cancer to do it, but some people can do it, Officially, it's, everybody can do active surveillance if they are candidates for active surveillance by the parameters of the cancer.
Well, it's a great question, and indeed, I personally don't have an answer because I'm not a billing specialist. I'll just, at the level of the common sense, I think what's happening, Medicare is covering, certain age group, as you said. It's providing coverage on annual basis for the screening. But if you are young of this age, but you have a high risk of prostate cancer because 2 of your cousins or your father or somebody else had a cancer, and you worry that actually cancer may happen not at age 40 but early. And by the way, cancer is not selecting date. It may start early. You're absolutely right. So it should be resolved on an individual basis. I think you have to talk to the primary care physician, and primary care physician should talk to the insurance, medical director of insurance, and bring the case on an individual basis and explain what the risk is. And then insurance may approve your claim. Well, very, very unfortunately, we cannot extend these resources indefinitely. We definitely have to be cost effective, but for those cases which have a high risk, I think there is individually tailored solutions.